Welcome, everyone, and thank you for joining us tonight. My name is David Dodick. I'm a neurologist at the Mayo Clinic and chair of the American Brain Foundation. We're really proud to be co-sponsoring tonight's event with one of our research partners, the Muscular Dystrophy Association. Tonight, we'll be hearing about really the truly remarkable cure developed for spinal muscular atrophy, which is a crippling neurological disease. The cure developed for this disease is now being applied to other diseases and is therefore really a beautiful example of why the vision of the American Brain Foundation is cure one, cure many. Because of the shared mechanisms across many neurological diseases, we believe if we can find a cure for one, we can find a cure for many, and tonight will be a case in point. As of today, the American Brain Foundation has invested more than $33 million in research and granted scholarships and funding to more than 270 researchers. And that money's been well invested because over 90% of them have gone on to secure NIH and other foundation funding for their research. The American Brain Foundation's most important partner is our founder, the American Academy of Neurology, which is the largest association of neurology in the world. Every research grant we make is vetted by the Academy's top scientists. So we're sure that we're investing in research that's going to truly be innovative and translational, which will lead to new advances in treatments for patients. Our foundation is committed to sharing valuable resources and increasing public awareness for brain disease, and really raising awareness of the desperate need to fund research for diseases that affect 1 in every 3 Americans. It's a lot of people. So, and our virtual salon events like tonight are opportunities to connect you with experts in various topics of interest around brain disease. So first up tonight, we're really very fortunate to be joined by Dr. Jerry Mendell, who is the recipient of the American Brain Foundation's first ever Scientific Breakthrough Award in 2019. Dr. Mendell is the Dwight E. Peters and Juanita R. Curran Endowed Chair in Pediatric Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital, and a professor of pediatrics and neurology at Nationwide Children's and The Ohio State University. He's a clinician scientist with decades of experience, has a career emphasis that began with training in neuromuscular disease at the NIH, directing laboratory research that could be carried to the bedside. His life's work has emphasized clinical translation, research that's going to translate into clinical advances for patients. He's published more than 370 articles with a focus on neuromuscular disease and authored books on muscle disease, peripheral nerve disorders, and most recently, gene therapy for muscle disease. Dr. Mendell, I've not told you this before, but you were one of the main reasons I attended the American Academy of Neurology. I attended all your courses when I was a resident, actually, and fellow. He was the principal investigator on the prednisone clinical trial in Duchenne muscular dystrophy in 1989 that has profoundly influenced clinical care. He was the PI on the exon skipping trial using eteplirsen, now FDA approved for clinical use in 2016. And he was the PI, principal investigator on the first gene therapy trials for Duchenne and limb-girdle muscular dystrophy, and was the PI on the spinal muscular atrophy gene therapy trial that was approved for systemic delivery to infants with spinal muscular atrophy type 1 in 2017. So we're really very fortunate and privileged to have you here tonight, Dr. Mendell. After Dr. Mendell, we're going to hear from Dr. Robert Griggs, Birch as we know him, who is deeply involved in muscular dystrophy research. Dr. Griggs is chair of the American Brain Foundation's Research Advisory Committee. He's also a professor of neurology, medicine, pathology, and directs the Center for Experimental Therapeutics at the University of Rochester, where he was chair of that Department of Neurology and the neurologist in chief from 1986 to 2008. He served as the editor-in-chief of neurology from 1997 to 2006. And he also served as president of the American Academy of Neurology, the founding partner of this foundation. And then finally, we're going to hear from Dr. Don Wood, who's the CEO of the Muscular Dystrophy Association since February 2021. Dr. Wood has been studying human muscle since 1973, taking basic research from the laboratory and applying that knowledge to human diseases, including muscular dystrophy, Duchenne muscular dystrophy, and ALS. So thank you all for being here. And now I'm going to hand it over to Dr. Mendell to give us his presentation. Dr. Mendell.
Thank you very much for your glowing comments, much appreciated. And I'm going to talk about gene therapy and how it's changed the outcome for children with neuromuscular disease. Tonight, we'll focus on spinal muscular atrophy. These are my disclosures. And I want to tell you that for the past 20 years, I've been deeply involved in gene therapy. And right about the time I got started in gene therapy, there was a dismal view of what gene therapy could potentially offer. Here's a Science magazine editorial that said that much too much NIH money was being spent on gene therapy. It wasn't justified, and there was no success that measured up to how much money was being spent. And there were early warnings about gene therapy from scientists. Gene delivery was presumably not going to be expressed for long periods of time. It was going to be short-lived. And this would be due to promoter shutoff. Up here on the top, I have shown a cassette. So it looks like when we put in the virus, we put that in a virus to deliver. We would have viral induced immunity that would block transduction. We would have novel gene expression that caused inflammatory responses in the liver. And last of all, we would have insertional mutagenesis, which would be random DNA insertion into the genome. Much of this actually came true, but we learned how to handle this, and that is how we became successful in our gene therapy approach. One thing I like to start off with is the virus is potentially used for gene delivery. And I also want to emphasize how which viruses we use for gene delivery now were sorted out by clinical trial. And by clinical trial, I mean translation. And it serves as, I think, as a great template for thinking about research and how important clinical trials are. And that includes patient participation and how much we need patient participation for clinical trials. Adenovirus met an unfortunate course in gene therapy. In the beginning, adenovirus seemed to be an ideal virus to transfer genes. It was very large. It could hold the entire Duchenne gene, for example, the largest gene in the human genome. And I was ready to launch a gene therapy trial using adenovirus. But virtually at the same time, in September 1999, there was an overwhelming immune response in a patient who was treated for ornithine transcarbamylase and died 4 days later. This kind of put to rest the potential for using adenovirus for single gene disorders. Next big problem was insertional mutagenesis, and I mentioned this a minute ago. Retroviruses for gene transfer can insert a replacement gene into the human genome. And in the beginning, we thought this was an advantage because if it was placed in the human genome, it would be there permanently and would not threaten short or not very long gene expression. And in X-linked SCID, severe combined immunodeficiency disease, 20 patients were treated and 5 developed T-cell leukemia. 2 of these patients died, and that is because when the IL-2R gamma gene was put in to replace the absent SCID gene or the muted skin gene, it randomly inserted into a region that was a cancer-causing gene, the LMO2 gene, and that kind of sealed the fate for retroviruses to be used for single gene disorders. So that brought us to adeno-associated virus. And really, there are a few things wrong with adeno-associated virus. One is its name, because it's very often confused with adenovirus. It's a single-stranded DNA virus. It causes no human disease, and I have these in quotation marks because what we have found is that it causes an immune response, and although it's not a disease, it does have potential downsides, as I'll mention in this talk. It has multiple serotypes. That's an advantage because we can choose different serotypes that are appropriate to use for targeting different organs. We use in our gene therapy trial for SMA AAV9, and for our muscular dystrophy trials, we use AAV-RH74. Its strength is that it's non-integrating. We wouldn't have said that 20 years ago because we worried about it not being able to express for long periods of time, but we found out that it's a good thing. It sets up its gene when it's delivered outside the human genome, and it's very safe in that place. Its weakness is it has a limited packaging capacity. So as I said, adenovirus can hold the whole Duchenne gene. Adeno-associated virus can only hold about a third of the Duchenne gene. Fortunately for spinal muscular atrophy that we're going to talk about, it can hold the entire SMN. That's the gene for spinal muscular atrophy, the survival motor neuron gene. So that's a fortunate one, and it can hold several other muscular dystrophy genes. So those principles, we took those principles and applied them to the SMA clinical trial. Now, one thing unique about the SMA trial, it was systemic vascular delivery. That means we put the gene in the forearm of these affected infants. And it was the highest titer ever given in a human gene therapy trial, which made all of us a little nervous at the time, but we had overwhelming evidence in the Delta 7 mouse that this was an effective form of gene therapy for SMA. And just to review briefly, to remind you, here's the genetics of SMA. There are two genes that are duplicated, SMN1 and SMN2. SMN1 has full expression of the SMN protein, which we need to rescue patients with spinal muscular atrophy. And SMN2 has a mutation at exon 7 and only produces a small amount. That's the gray circle there that you see of SMN. That's not enough for survival. If the SMN1 gene doesn't express, as it does not in SMA, then it leads to its lethal outcome. But what we can do is we can take AAV and load it up with SMN and have SMN replace the SMN1 gene, and now we can get full gene replacement. Of course, when we started, we had no idea how successful it would be. And this is what we were trying to accomplish. This is the survival curve for spinal muscular atrophy. And as you can see here, there's a 50% survival by 10.5 months, a very sad outcome, but it gets worse. By 20 months, there's 92% of the infants die, or only 8% survival. And by 2 years, virtually all are gone. So that became the primary outcome for this clinical trial. Now, here's the picture of the protocol for the clinical trial. 15 SMA patients were selected, and each had 2 copies of SMN, like I showed you. This is a dose ascending schedule. So cohort 1 was to receive 6.7 times 10 to the 13th vector genomes per kilo. And those were going to be the first 3 patients. And then the ascending dose was 2 times 10 to the 14th vector genomes per kilo, and that would make up the remainder of the 15, depending on how things went in the first cohort. We used prednisolone for immunosuppression, and this was introduced after the first subject, and I'll show you why on the next slide. This study was started in partnership with us with a small biotech company called Avexis that later sold their license after the successes we had to Novartis, and now in retrospect this is called the START trial. Here's a picture of one of the first patients that we infused with the virus. The reason I show this picture is to tell you by observation that this is a very well tolerated virus. When we inject the virus, there's virtually no reaction from the child, and that's true for all the trials we've done, whether they're in SMA or muscular dystrophy or inclusion body myositis or whatever. And but within a short amount of time, we have vomiting that occurs in at least 60% of the patients by the third day, and we have liver enzyme elevations. And we also, this is an example of liver enzyme elevations on the blue peak that you see there, and it's associated with immune response to the AAV capsid. These things often go together. And in the first patient, the very first patient with 6.7 e to the 13th, we had this very marked liver enzyme elevations that reached 12 to 1400. And I went to the FDA and said that we need a protocol change to use immunosuppression for this when we inject further patients, and we would inject prednisone 1 day before gene therapy in order to suppress this immune response, and we'd maintain it for 30 to 60 days. The FDA permitted that, and then on these next two patients, still in the low dose cohort, you can see that liver enzymes were markedly within a normal range. A little bit of immune response here, but prednisone served very well. And I'll tell you that since that time, we have used prednisone in every single gene therapy trial we've done, whether it be Duchenne, limb-girdle, or any other clinical trial. And it's very valuable to be put in this place. And one of the things we've learned in gene therapy is what you learn in one trial can be translated to another. And here's the full picture of the survival in the gene therapy cohorts. After cohort 1 that received 6/7 e to the 13th, we started using prednisone 1 day before, you can see here, and then when we went to cohort 2, every patient in cohort 2 received that, and every patient in this trial survived. Now 8% survival was the target, and we had 100% survival at 20 months and 100% survival at 2 years. Now, that doesn't tell the whole story, obviously, because now we've done a long-term follow-up study on these first 15 patients to address whether gene therapy is persistent. And we have patients now that live out to 6.5, and I saw one this past week that was out to 7 years post the first gene therapy infusion. And importance is that there was no regression in any gain milestones. And here were the gain milestones in that first trial. We have 2 patients who walked, 2 patients who were standing here in green, and every patient in this trial was sitting. So at the very least, we had converted patients, if they were treated very early, into virtually normal infants. And we had patients who were treated early but didn't do quite as well because they had a lower CHOP intent at the start, but still did well. Here's one that learned to stand and another that learned to stand. So this was basically converting everyone to either SMA2 or SMA3. And here's the picture of that. Here's, if they had a high CHOP intent at the start of the study, we had very good outcome. if they had a low CHOP intent at the, and I'll say before saying that, when we have another study we recently did that was a sprint trial to match the patients who were in this very early stage. They had no symptoms, and all 14 at 14 months, every patient in this trial had converted to type 2, and they all learned to sit, and we had some that were learning to walk at 14 months. So this validated the initial trial now based on treating newborns. Back to the original trial, if the patients had low CHOP intent to start with, they could still improve, but didn't improve as much as those that had high CHOP intent. If they came into the trial with poor scores on CHOP intent, meaning they had lost multiple neurons, we couldn't treat them effectively, and they never really did improve. So this tells you that early treatment has the best outcome for these patients, and that's why newborn screening was put into place, and newborn screening then could basically, as was said by Jane at the beginning of this, could virtually cure all patients. So this was further validated in another trial that was recently published in Lancet Neurology, and what this shows is that a trial that was 22 patients receiving the same dose as initial, it says 1.1, that's not a mistake, that's a different method for titering the virus, but now we have virtually the same outcome. If we treat them, this is treating patients very early in the course, and we have patients who are surviving completely, and here's the natural history curve. So very striking outcome with early treatment and reproducing what we saw originally. So we have trials now that reproduce early treatment, trials that reproduce this was a phase 3 trial that led to confirmation that we for approval, and we have long-term results from our first trial. So a full picture of everything that we had intended to and hoped to show from the initial efforts. And here you can see some of the examples. Here's a patient who very early treated, dosed at 2 months. By 6 months, had good body control. This is from our first trial. Here's a patient who had return of reflexes in SMA, and this is virtually completely unknown in SMA. And here's one of our star, very early treated. Now you see him here able to climb a wall. See him here able to hang like a ninja warrior. You see him here walking off and taking an elevator to the second floor to his new office. And here he is with his principal investigator, and that's the best part of the story. So the first trial was awarded the Science Breakthrough of the Year Award. I was very pleased about that. The article was published in the New England Journal. And that's, I think, as much time as I was allotted. And you can see now that we're making great progress thanks to the team of researchers at Nationwide Children's Hospital. I'd like to show this part of our team is our physical therapists who do all the outcome measures for the trial and are critical for any success that we have. So I'll stop there and throw it open. Thank you.
Thank you so much, Dr. Mendell. Fantastic, really inspiring. Dr. Griggs, some comments from you, please.
So I would just, let me say, I'm pleased to see that our audience is, we have a good audience, and it includes Jerry Mendell. Will be interested to know that Dr. Valerie Ascanis and King Engel, with whom he trained some close to 40 years ago, are in attendance. I think we have attendees from Australia, Elizabeth McCusker, and Alistair Corbett, and we also have people that I know who are interested in this disease from around the country. So I'd just like to congratulate Jerry on this work. And he's talked about spinal muscular atrophy, but it's important to recognize that he also has been working on other diseases. And he mentioned what many people feel has been the worst disease of mankind, Duchenne muscular dystrophy. Now, you could argue which is the worst, but certainly Duchenne muscular dystrophy was challenging to all of us early on, including Don Wood, who was investigating this disease very early, as well as other muscular dystrophies, and led MDA's scientific research enterprise years ago before returning now as CEO. So this is a disease of great interest. So Jerry, I hope you would be able to just comment for a minute about Duchenne dystrophy, limb-girdle dystrophy, and in passing, you mentioned a non-genetic disease, inclusion body myositis, and for which you've got a gene therapy strategy. So you don't have 15 minutes for each, but perhaps you could just touch on them quickly.
Yeah, I mean, well, since you mentioned Valerie and King, the first patient I saw with Duchenne was at NIH. I often show the picture of that patient. It was inspiring and a commitment that we really had to do something for this disease. And we took all the principles that we learned in SMA and applied them to Duchenne. We took the high dose vascular delivery. We took the dose. We took all the principles of excluding patients with that had pre-existing immunity. I didn't discuss that much because of the time, but we learned all those things. In the first trial, in our pilot trial, we treated 4 patients, ages 4 to 6, with a cassette. Now, I mentioned that in SMA, we have major advantages because we can put the whole gene and the whole cassette into the virus, into AAV. In for Duchenne, we can't do that. We have to take the gene and we have to dissect it down or cut it down to only include the critical parts of the gene, and that is about a third of the initial gene. So we take, instead of 14 kb, we have a gene now that for gene replacement that's 5 kb, and that fits nicely into AAV. We can then deliver that at this very high dose, these similar side effects early in delivery. But we start seeing improvement in that disease within about 6 to 8 weeks. And virtually every child that we've treated has improved with that form of treatment. So after the first trial, we did, then that was an open trial that was published in JAMA Neurology. Then we went on and did a trial that was randomized controlled trial of about 40 patients now. And that trial is also showing similar results with virtually all the patients in that trial improving. Now we're about to embark on a phase 3 trial that will be a major commitment of a randomized controlled trial that will now include 40 sites. The numbers will be up to 120 patients. So quite an undertaking, but we hope that would lead to a product approval. And I think if you saw the patients that we follow up after gene therapy, we have data now out to 3.5 years post our initial gene delivery, with continued maintenance of improvement and no regression of findings, no loss of function. So it's looking very favorable in Duchenne. We have similar results on a smaller number in about 6 patients with limb-girdle dystrophy type 2E or beta sarcoglycan, and those studies are being extended to to alpha and gamma sarcoglycan. And you mentioned about IBM. This was a strategy that I had hoped would work. We did inclusion body myositis. For those of us who are very familiar with this disease for one reason or another, I know you are, Birch, the patients have quadriceps atrophy and finger and hand grip weakness due to muscle atrophy, and the histology is very unique. I won't discuss here, but because of the atrophy in the quad, and that's what led to the debilitation and the loss of ambulation, we used a gene that would increase the size of the muscle, that would inhibit myostatin. And the most powerful inhibitor of myostatin is follistatin. We loaded up the AAV virus with follistatin, injected it into the quadriceps muscle, and we got significant improvement in ambulation. I think we've learned a lot since then, and if we were to repeat that trial, we would do it by intravascular delivery rather than by IM. In the beginning, we were limited. When I first started gene therapy, in fact, the first gene therapy trial I did was in 1999, and we had to inject the virus intramuscular because we had no tools powerful enough to make the amount of virus that we need for one of these clinical trials. So things are moving along, and I'm busy and enjoying it. So glad to hear that my mentors are here.
Don, some comments from you, please. You're on mute, Don.
Sorry, I had to get myself off mute. I was actually saying some very profound things while I was muted, but now I've kind of forgotten what I was saying. Before I start, it's like sort of an old home week for me for both King and Valerie. So I'm saying hello to them as well. I know, Jerry, you work with them, and I remember spending a great deal of time, especially with Valerie, on a couple of international conferences in neuromuscular diseases, and she taught me lots. And King, on the other hand, simply directed me where to go, which was pretty cool. I think for everybody on this call, we know, Jerry, that from a historic perspective, this is incredibly pioneering work. We are at the start of a new age of medicine, what I call genetic medicine. We are learning things we never, could have possibly known back in the day when I was in the college and all of that. You didn't study genetic disease because the feeling was you weren't going to be able to do much for treatments. And certainly at the time, they were still learning how the technologies and developing technologies to try and even identify a gene, even on what chromosome it was. Just as a point of asterisk historic fact, I was actually on the first Nature paper identifying which chromosome we thought the gene for spinal muscular atrophy was located. And so having gone from that point to where we are right now is amazing. But like I said, it's a pioneering effort. And it's a pioneering effort, not from the science and the medicine, but one of the things that I think we all need to appreciate, it's also a pioneering effort when it comes to the health insurance companies and to FDA. FDA, from a historic perspective, these are the first times they've actually had to look at clinical trials related to genetic disease, where relative to infectious diseases, the numbers of patients are going to be way smaller. And one of the things I wanted to ask you, Jerry, was something on the order of how do you see FDA, or maybe that's not the right way to ask the question, but how do you see us going forward with gene therapies for diseases that have very few people, where you can't put hundreds and thousands of folks into clinical trials, but working with much smaller numbers of folks where it's very difficult to develop big numbers, and you're only going to be able to do small numbers. How do you see what we've learned right now helping us understand how to go forward with some of these more ultra rare diseases?
I think your point is well taken. We do have challenges when we think about treating diseases with small numbers, but if we use the same template that we used for success, like in spinal muscular atrophy, I think we can have potential application to these other diseases, and I think that's our best chance. And there is a template for moving things from the bench to the bedside, and that is to have a very good animal model. If we have a good animal model for the disease and we have very good preclinical data, then I think you see initially even very small biotech companies who will invest in that and doing small pilot trials. Then if they're successful, they move on to bring in big farm like Novartis and now Sarepta and other big pharma now. So I think the key is if you have a small disease, you have to have a good animal model to show efficacy, and you have to have no toxicity at the level of efficacy. So those are the best formulas that I can imagine, and that can be applied to many diseases, even with small numbers.
Talk about, if you will, the advantages now of early screening for children with possible disorders by spinal muscular atrophy and Duchenne muscular dystrophy in terms of time of treatment. Obviously, the earlier you can treat them, probably the better outcomes, as you have shown. But what about for disorders like that come in later in life, or well, they're always there from a genetic perspective, but clinical symptomology that drives them to the physician's office doesn't happen until they're teenagers or later, like with limb girdle, etc. How do you see gene therapy evolving in those areas in terms of when to treat patients?
Well, I think that one of the things we've learned, both in Duchenne and in SMA especially, is that if you treat pre-symptomatically and protect the target organ, whether it be nerve or muscle, you basically have a winner. You've got the mutation sitting there, and if you can replace that mutation and repair and actually treat the target organ before the onset of the disease, and that can go for limb girdle as well. I think that's a good example. If you can take and treat a limb girdle patient, we know, I don't know whether you're aware, but we did the big Ohio study on newborn screening. That was 40,000 patients. And what we showed in that, using a two-tier method, is that we could take the dry blood spot and do DNA on the dry blood spot, and then that demonstrated the mutation, and that would lead to then to potential therapy for those patients. But in that trial, we found significant numbers of limb girdle patients as well, and those patients would have been susceptible or could have been treated with gene replacement very early. And if they had been treated very early, that basically would have rescued their muscle. Even though they had later onset, I think that the gene replacement, even at this early time, would have protected them. So I think the potential is there, and the principles are being demonstrated now. We don't have a lot of serious side effects so far in the gene therapy world. Yeah, I mean, we have the Jesse Gelsinger affair, where we had a high significant immune response that was treated with adenovirus. We had that we have had rare events But using AAV, we have had a pretty benign course. Now, having said that, I am aware of the myotubular myopathy patients who had a tragic outcome. But what I think we have shown also in our initial studies is that the dosing of 2e to the 14th vector genomes per kilo is close to the highest toxicity, the maximum tolerated dose. And if you try to go above that, you do potentially jeopardize the patients by giving higher doses than 2e to the 14th. But myotubular myopathy was unique in the sense that it also carried, many of the patients carried an underlying liver disease along with their muscle disease as part of their myotubular myopathy syndrome. So I think that was contributory. So I think that I think the AAV total titer that we've been delivering at 2e to the 14th is about as high as we can go. I think if you give that to patients pre-symptomatically, you have a very good chance of rescuing the phenotype.
Thank you very much. I think now, Dr. Dodick, maybe we can open it up to questions and answers.
Absolutely. For those of you who would like to open your mic and ask live, that would be great. Otherwise, please feel free to type any questions into the chat, and hopefully we'll actually hear from Dr. Mendell's colleagues and mentors who have joined tonight. But there is one question in the chat here, Dr. Mendell, and that is, prior to gene therapy, what was the prognosis for the typical SMA baby, and how does that differ with those who have had the therapy?
Well, we haven't lost anybody from who's been treated. I should be careful when I say if you treat late, you do jeopardize the patient. There's been no patient who's been treated early that has that did not go on to virtually full recovery. So that's the early treatment, and that was the result. Once we got gene therapy approved for SMA, we had state after state then approve newborn screening. And right now there's 38 states that have newborn screening for SMA. So if a patient's diagnosed within the first week of life and the gene is delivered there, that's virtually a complete rescue. If you look at that in comparison to the outcome pre-gene therapy, 92% or 92% of patients died by 20 months of age. So it's,
and for the audience, because we have some non-physicians in the audience here, can you remind us all again just what you mean by early versus late? What is early and what is late when it comes to SMA?
oh, I would say early is less than 6 weeks, treating before 6 weeks of age.
Okay. Very good.
So what about for Duchenne dystrophy? What is early? Do you think we should be doing newborn screening for Duchenne dystrophy and treat them really early?
First, I have devoted my life to try to get newborn screening approved for Duchenne. I've been to the heritable committee on heritable disease for infants and children and discussed the Ohio study for newborn screening in Duchenne is the largest study that's been done in the US. There are larger studies in Europe, but that's when we changed the initial projection of 1 in 3,500 to 1 in 5,000. 1 in 5,000 is a universal number for incidence of Duchenne. And when I went to the Committee on Heritable Disease in Infants and Children for approval, based on I presented the work. We had one, that we could diagnose it in infancy, at newborn. 2, that we had steroids that changed the natural history. We had exon skipping that changed the natural history. Nothing as dramatic as gene therapy, because we we didn't have the data at the time we did the newborn screening study in Ohio. But they said that we needed, at least 2 to 3 times as many patients for newborn screening. We're working on that. I'm working with a group at MDA to try to get newborn screening approved. I think we have enough data now. If people really look at the results of the gene therapy and the disease is so dramatically reversed, I think if we can get of course, if we could get that approved by the FDA, it would be unequivocal that we would have newborn screening. But if I think even without approval of the final product for gene therapy for Duchenne, I think we could. We have enough. We have enough products on board that change the natural history of the disease, that would allow us with early treatment. And you asked about what we're doing in the gene therapy. We just when we first developed the protocols for gene therapy, I took the IND to the FDA for approval. I asked for approval for newborns, for 4 to 7, and for over 8. We decided that we would start with 4 to 7-year-olds because within that group, then we have the best chance in the shortest amount of time to show efficacy. Because the Duchenne patients can improve up to about 6 to 7 and then start declining. So we have the best chance of showing improvement in that group in the shortest period of time, and that's basically what we've done. Now we're lowering the age right now for gene therapy, and we're starting with 3-year-olds, and we will continue to lower that with continued safety dosing. I'm working with Sarepta on those protocols right now.
I wonder if I could add something to what Jerry just said, because the question is so important for that, and relates to the earlier question I asked Jerry about the time for treatment, when treatment could occur, and Jerry's response was no surprise to me, is that the earlier the better, and the concept that you would not approve newborn screening for people with genetic disease, especially in cases where we now have treatments to start, and we have data going over several clinical trials and even several years in many cases that show improvements in patient outcomes. Tells you how pioneering this research is. I have a feeling that down the road, Jerry, there will be MDA and I am passionate about getting newborn screening. I think everybody with a genetic disease should have newborn screening. We've got the technology to do it, and we ought to have we need to push it forward precisely for the reason you said, which is that the earlier we can give treatments to folks, the better it will be. And the earlier we know about that an individual has a genetic disorder, neuromuscular genetic disorder, or any genetic disorder, we can start looking at the natural history in more detail. We could try looking for newer ways to screen for elements that indicate or diagnose the disease that could very well be markers for clinical improvement in any kind of treatment. So there's a tremendous amount here that we can do in terms of moving forward with getting patients involved and beginning even newer studies to understand the nature of how these diseases progress and how to better treat them. So, Jerry, I can't tell you how much I applaud the pioneering work you're doing, and MDA is very much, as you know, be behind it for now and until we cure these disorders. So thank you very much.
So one thing I just call attention to the fact we've been talking about nerve and muscle diseases tonight, but we have to remember that there are brain diseases that are genetic, lots of them, hundreds of them. And many of these will probably be amenable to similar strategies to those developed by Dr. Mendell for spinal muscular atrophy and for muscular dystrophy. And I think the future will be, I mean, if you even diseases such as Alzheimer's disease will have major genetic factors that are responsible for it. And I think the future is going to include efforts to begin treatment very early once we know, can identify patients early. And I think we're getting so we can now identify many brain diseases very early in life. And I think it's likely that the cures we're seeing now in diseases of the motor neurons, such as SMA, are going to play out in the future in many other diseases. And that's one of the important points that the American Brain Foundation has seized upon, is that what we're learning in one disease is eventually going to help us to treat many, many other diseases.
Well, seizing upon that point, Dr. Griggs, and given the fact that we have 3 renowned neuromuscular specialists here, there's a question in the chat about a potential path for treatment for something like amyotrophic lateral sclerosis. We know that the majority of those patients it's not due to certainly an autosomal dominant gene mutation, but what does the future look like for potentially gene therapy in something like ALS?
The problem with ALS is what you just said. We don't have a single gene to target, and except for some of the rare forms that are that don't represent the majority. So I think it's a tough disease, and we'd have to have an alternative approach. I've heard of combinational therapies like using NT3, for example, to delay axonal or motor neuron degeneration to promote regeneration, but these are all tangential. I think until we really get a clearer picture of where the target goes in ALS, we're going to have problems. And I haven't been working on it, so I'm probably not the best one to answer. But I think we need a target to load up our cassettes and to make a difference right now.
Yeah.
Yeah, at MDA, we're focused still on the fact of trying to figure out the pathophysiology, pathogenesis of the disorder, and it's complex. I think we're going to end up with, one group with a kind of a major consistent disorder, but then a lot of subsets. I mean, that's what it looks like right now, without actually being able to target what triggers it. That's one of the biggest problems. We don't even know if genetics triggers it. Even in the rare cases where we can identify a genetic disorder, anyway, it's complicated.
Yeah. Well, there's
let's be optimistic about ALS, because as Jerry points out, there are at least 50 known causes of ALS, and probably an equal number that we don't yet know. But in at least 2 of the rare diseases, there looks like there may be treatment. And so I think that it's going to require, I think Don's question about what we do about rare diseases is going to be very pertinent, because many of them are quite rare. But I think the strategy Jerry has outlined in terms of identifying the gene, and particularly if it's an autosomal recessive disorder, they will be amenable to the same treatment. But then there are nucleotide repeat diseases for which there are now genetic strategies, and the commonest known form of ALS, C9 open reading frame disease, which affects about 10% of patients. There is active work that holds promise, I think, for knocking down the abnormal gene in this disease. And so I think that the future is going to include genetic strategies even for these diseases that are still a scourge of mankind.
Yeah. Well, the time is running a little bit late, but there is one more question in here, and it has to do with newborn screening again. And the question is, are we talking about screening every infant or those with a family history? And what is the screening method? And I guess part C to that, I'll add, why are you having so much trouble? Is it cost effectiveness? Is it an obvious phenotype? Is it the lack of approved therapies? Exactly what walls are you running into? So can you answer those questions, Dr. Mendell?
Yeah, and newborn screening is screening of every infant. It has nothing to do with family history. It's a dry blood spot. It's approved by a national committee, which is the Committee for Heritable Diseases of Infants and Children. But that information, if they approve it, that information is then taken to the states, and the states have the final word about whether to approve newborn screening. But it is every infant. It's done on dried blood spots. Right now, most of the states do about 38 screens for in the newborn period. So that's basically how it's done. And you know, I guess that answers your questions, or was there one more?
Well, there was one more, and that's why are you running into walls? Why isn't this done already?
Oh, running into walls is the easiest answer. These committees and states want definitive treatment. Definitive treatment basically means FDA approval for the treatment. Once you have FDA approval, newborn screening is basically a lock. It's a shoo-in. So as soon as we get approval for Duchenne, and I think based on our clinical trials, knock on wood, I don't want to, I mean, I'm looking for approval within, I don't know, not that long. I don't want to give a number, but I think we're looking at a reasonable period of time. We'll have approval for Duchenne, and then we'll have no trouble with newborn screening for Duchenne.
Great. Thank you very much. Well, listen, Dr. Mendell, again, I applaud you as well for your pioneering work. It's truly remarkable, and we were quite honored to present you with the Scientific Breakthrough Award in 2019, the first ever from the foundation. So thank you very much for being here tonight and for everything that you continue to do. Dr. Griggs, Dr. Wood, thanks so much for being here tonight, and appreciate the conversation and your insights. I also want to, before I say goodbye, I want to thank everyone else for joining tonight. We host virtual salons like this every month, and we'd love to see you again. And here's a slide of, I think there's supposed to be a slide of upcoming events. Yeah, here we go. So research in Parkinson's disease, what's giving us hope? Research in multiple sclerosis, what's giving us hope? Acute stroke treatment and mobile stroke units. So please join us if you can. We'd love to see you. You can also follow us on social media to stay up on data with regard to brain disease and research from both established investigators and our junior clinician scientists who receive awards. We thank you for generously donating to the foundation, and you can also continue to support by making a donation. There isn't a donation that's too small, and everything is deeply appreciated, and we simply can't do this work without your support. So thank you all again for being here. Have a great night, and we'll see you next time.